Hey, everybody, welcome back. This is John Malanca, the host of Association of Cannabinoid Specialists. In our top right-hand corner, we have Dr. Sandra Carrillo, we have Dr. Jordan Tishler, Dr. Suraj Tandon, and Dr. Adam Abodeely. So the topic, this one is, I think, near and dear to all of our hearts because of the industry that we're in and wanting to help and educate. It's limits of budtenders and the limits of budtenders. And this topic comes up quite a bit I'm in California, and the law, since California's been legal since 1996 at the medical level. In 2016, it was voted in for adult use. I was one who voted no on it, and I got a lot of slack from my colleagues in this industry. Why would you vote no? It's not that I don't want legal access for patients, because if it wasn't legal in the state of California, we wouldn't have been on this journey that we're on right now, for me at least, with my father-in-law, et cetera, and then starting United Patients Group. The reason I said no is because I think education, doctors are still needed in this. It's not a one-size-fits-all medicine. It is considered a medicine. You generally look at age, weight, current health conditions, drug-to-drug interactions, as well as sensitivities. And going into dispensary, which I think is fantastic. Back in 2010, when we started, it was the wild, wild west, no labeling, no testing. You'd go in there and they just put names up there just to sell them. Now, as time has gone on, education is set in, regulation is set in, and safety has set in so many, not in every section here. The reason I say that, chances are there's some great budtenders out there, there's some great dispensaries, but a lot of times the budtender is not well educated on a patient at 20 up to 80, blood pressure medicine, diabetic, et cetera, as well as sensitivities. And so that's why I think this casual conversation is very important for the other medical professionals that will be watching this as well. And so, and one last thing, and no disrespect to dispensaries, but a lot of these budtenders, because it is a cool, hip industry to be in, they may have been working at Costco or Starbucks last week, and now they're dispensing medicine to a patient. And so I'll stop right there. And let's go with those ladies first. Dr. Sandra Carrillo, always great to see you. And love to hear your aspect on this, because you're not in the United States. You're in South America, and but you do travel nonstop. I do know that. And so you're very familiar with cannabis, not only here in North America, South America, and around the world. But I'd love to hear your thoughts on this.
Yes, thank you, John. Very happy to be here discussing this very interesting subject. Definitely, this is a delicate subject because, as we were talking earlier, I think the budtenders, they have a certain knowledge about what they're selling, but it will never be compared of the knowledge of a doctor, the preparation, the training, the expertise, the amount of papers and research that we read before we issue a prescription. So it is totally different, because we know about drug interaction, side effects. We have to learn about the comorbidities that the patient has. So for a budtender, it will have to go through almost medical school to learn about all these things. So I think in the United States, that is a challenge for doctors, because in Latin America, we issue a prescription, and the prescription is dispensated in a pharmacy by a pharmacist, but the pharmacist will just give what is written in the prescription. He cannot recommend anything extra or something different. It's a controlled substance, so it will be just as buying an antibiotic or another controlled substance that you're buying in a pharmacy. So for us, we don't face these challenges, But I see, as you mentioned, in other parts of the world that this is very challenging because you need the training and expertise in order to recommend the the elders, and when it's for children, there's so many situations that you need to consider, and you need to learn about the physiology and the side effects and drug interactions. Definitely, I think it's challenging, and for doctors, it's very challenging because we prescribe in Latin America, but in United States, it's a recommendation, and then it's tricky because at the end. We don't know if the patient is getting exactly what the patient needs. So yes, it's very important to address this situation.
I work with a lot of pharmacists, and they're frustrated because they feel that they should be, because it is a controlled substance, that they should be more involved. And they are starting to become more involved and educated on this plant. So from Latin America, we'll keep on passing through the US up to Canada to Dr. Suraj Tandon. How are you doing?
Good. Thank you again, John, for having us and hosting this. I agree with my colleague here, Dr. Carrillo, in terms of, I want to preface by first saying that none of us mean any disrespect to any of the Budtenders. I think they are a vital and essential component of providing customer care to dispensaries. So I think that's absolutely necessary. Now, I'll give you the example of, let's say if, for example, you have a patient who requires brain surgery. I think if someone needed an opinion of whether they needed surgery or not, I would expect that a neurosurgeon, an expert within that discipline, be the one making the recommendations to proceed with surgery or not, as opposed to a medical cannabinoid specialist like myself. So I think similarly so as Budtenders, I think they can provide, recommendations with respect to maybe products that might have a specific flavor or, a profile that might be within the confinement of their expertise. But when it comes to medical advice, I agree that they should not be providing, those opinions. And again, as Dr. Carrillo had mentioned, that, there's a whole robust amount of data to show that, there is potential drug-drug interactions. There are, significant form of disease that needs to be considered when incorporating various types of cannabinoids, especially for medical purposes. I think the other thing I want to say is that I've had certainly here being in Canada, now having decriminalization, full legalization of recreational cannabis in 2018. Prior to that, it was a bit easier for us to guide and recommend, medical cannabis use for patients because it was really done through the licensed producer directly. So from the manufacturer, again, as Dr. Carrillo mentioned, here in Canada, patients had access to medical cannabis via a medical document or also known as prescription. But parameters in terms of, what their cannabinoid product would be, THC restriction, et cetera. Now, since the legalization with recreational cannabis, it's really convoluted things, and it's made things a lot, I would say, from a medical standpoint, a bit unsafer for patients who want to now consider implementing this into their plan of care. Going to a dispensary down the street, not necessarily under the supervision of a provider, can lead to two things. One is accidental overdose or intoxication, potential unwanted side effects. And then two, or thirdly, I would say, sometimes, I've had many patients who've now come to me or afterwards and realize that, or a bit hesitant to try cannabis because they said they've tried it themselves by going to a dispensary, and perhaps they never achieved the most optimal dose or the duration of treatment. And so that also then, convolutes, it sort of confuses the situation, whether they were optimally trialed on medical cannabis or not. So those are my sort of points there.
Let me throw in here, and then I'll go to our. Oh, what would you say?
I was just to say, and the other thing to your point, Suraj, is that they may have spent $600 or $800 not getting to where they need to be and be frustrated and bankrupted through that process, and that's pretty unfair too. I think that we also have to acknowledge, in addition to the Budtenders' limited medical and scientific knowledge, that they work for the selling company, and therefore there's a conflict of interest. And I've had people tell me that the manager comes along and says, oh, this package, these products are getting old and are about to expire, so let's make a sale and let's push these products. that's a conflict with, Joe Schmo comes in and they need something for a specific purpose and they get given the thing that's, about to expire. Sorry, John, go ahead.
That's exactly where I was going to go. Is about a selling point. What's the hot topic for the hot item for the day? Let's get it out of here. Let's get out of here. And I've seen that now with regulation. I've been, living in California and being in this industry for 15 years. I've seen so much from the growing side to the vending side to the dispensary side, and just being part of this. I've even taken tours. I brought for you, Sandra, I've taken pharmacist tours. I said, you want to see what it's like going in? And I brought them. I'm in the San Francisco Bay Area, and I did the good, the bad, the ugly, and I different dispensaries in the San Francisco Bay Area, and they were blown away. They were blown away. Like, how are they doing this? And so they were very frustrated, feeling how I have my DEA license to administer controlled substance, and how is this? And a lot of times we went in there. A lot of times we went in there and you'd ask for something. No, we don't have it. I'm like, it's right there. So the education part is not there too. And so, yeah, that's what I was saying. And then overselling. And I've worked with a lot of seniors, as I mentioned off camera, that come out with 8 different products to treat everything: sleep, anxiety, depression, bop, bop, bop. And I said, sometimes if you just treat this, it's a domino effect. The sleep will take care of the anxiety, the depression, etc. So, Suraj, you were talking about surgeon. We have a surgeon, Dr. Abodeely. So if you want to add to that.
Yeah. So, the challenges that we've had with Budtenders, I'll say is definitely been a real challenge, but as we've all, as we've alluded to, where there's a challenge, there's an opportunity, in the sense that Budtenders really are a first line of information for a lot of people who go into a dispensary, whether they're a medical patient that is, bypassing the doctor to go directly there, or if they're just a consumer. But they do have a real ability to help society, to help patients, which is why which is why we as an organization want to invite Budtenders into our organization, because we all want to work together and to make sure that the messaging is getting out in a way that is sustainable and is real. And so I can tell you my personal challenges with Budtenders date back to 2016, when New York State first legalized medical cannabis, and I started certifying patients. Our certifications would go to the dispensary, which would then be handled and intake by a budtender, who in New York State at the time, these were had to be licensed pharmacists. So we'll call them highly qualified budtenders, if you will, understanding physiology, understanding the chemical components and makeup of cannabis. But there was a disconnect. There was still a disconnect. And here's an example of that. So I had a patient who I had recommended an inhalational form of cannabis. And then the bud tender, who again is a pharmacist, understands the physiology here, said, hey, that's great. But, maybe, you have inflammatory bowel disease, maybe you should consider an oral compound as well. And they took the advice and came back and I asked the patient, how's it working? And come to find out it wasn't working very well. And then I find out, I asked, well, what have you been taking? And it finds out that per the recommendations of the bud tender, the pharmacist, he was taking an oral, some gummies and some tinctures and things like that. And so at that point, I decided to call the pharmacist and just said, here's the problem that we have. And I said, so did this patient tell you that although they have inflammatory bowel disease, they also have really high output in ileostomy? They have chronic diarrhea. We battle to keep any oral absorption. We have the patient on medications to help enhance intake of nutrients through their GI tract because they have a clinical short gut syndrome. Did they share any of this with you? And the answer was no. And I said, well, these are the reasons why I was really recommending my patient to have an inhalational form. And so it was at that point I had some discussions with the pharmacist and said, we either treat this as a medication or we don't. But so, there's where the disconnect is. And these are the same disconnects that a bud tender will have. A bud tender is not going to understand the intricacies of a patient. Now, the second challenge, of course, is the general conflict of interest. And this is something that is becoming more and more of a big problem, not just because of the challenges we talked about with, supply and, keeping your shelf stock, from expiring, all these things that drive bud tenders to maybe potentially sell products. But also now behind every product now is a brand. And so if we may recommend a THC ratio, for example, or concentration, but if that brand, maybe that dispensary has that brand, but it's packaged and it's marketed towards women because it's pink and because it has, or it's marketed towards someone who's in their early 20s, that's a snowboarder. We see now all these different brands. And so brands also fit a persona. And so when you start taking, that out of, and you start throwing that into the mix, now bud tenders have the ability to influence, consumers in a way that is really far away from, medicine. So, I personally wouldn't care if, someone, I would tell someone, I know that you need, I'm suggesting a 10-to-1 ratio. I know that you bought a package that's pink, and I'm sorry that's what you had to do, but that's where there's some disconnect. There's not, we can't go into a pharmacy and the pharmacist can't say, there's 6 different blood pressure medications, which one do you like the package of the best? and so, so there's where we have to really delineate, a medicine versus a product that is being sold like any other retail product, unfortunately.
Can you talk about the bud tender training course?
Yes, thank you. I think that if you've been listening to the discussion this evening, it's very clear that we have respect for the bud tender and feel that they're an important part of this chain. And in some ways, what we've done is we've designed a very short, focused course for bud tenders to help them understand what we need in order to work together as a team to get the patient what they need. And it ranges from relatively sort of mechanistic tasks like, if you're recommending a tincture, tinctures are medicine in a liquid, and so they need to be a concentration. How much medicine is how much liquid, so that we can know, or the patient can know, that they're taking the right dose. I think a lot of people who are bud tenders haven't really thought about that kind of science since maybe early high school, So we went and did a review of those sorts of things. What are grams and milligrams? What are milliliters? What's a concentration? Those kinds of stuff that they need to know. And then there's a separate section, which is sort of, how do you interact with the doctor, right? Unfortunately, I've had the experience of my patients telling me that the bud tender said, "Oh, I don't understand what your doctor's talking about. Forget what he said. I'll tell you what to do." And not only does that lead us to a bad place for this patient, but it's not a professional collegial relationship. And when we think about the conventional pharmacy system, those pharmacists know how to reach us, right? It might be electronically, it might be the telephone. But the point is, if there is some question about what the patient should be getting, or sometimes even the pharmacist says, "Hey, I've got a better idea," rather than subvert the process, they reach out and we come to an accord, and then everybody is on the same page and it moves forward. In some ways, I actually feel a little bad for the bud tenders, in the sense that they are in this awkward position between their corporate overlords, if you will, and sort of the actual taking care of the patient. And they're really put in this position where they're kind of being told, you got to give this advice. Maybe it's to sell a product. Maybe it's just your best guess without enough training or without a medical degree. And it puts them in a very awkward position. And I think, if we start to think down the line about medical liability, they're in the line of fire, and they shouldn't be, right? They need to be, right? I mean, if you're talking to a pharmacist, they know their field, and they're licensed, and they're responsible for what they say and do in that context, just like we all are. And the bud tenders are not licensed, they're not trained, they don't necessarily have the ability to meet that bar, and that puts them in a very awkward position.
What I'm seeing popping up not only here in California, but all the way out to the East Coast as well, that you are seeing nurses and some doctors, medical professionals, that are stationed inside dispensaries now. So there are, like I was mentioning earlier, the good, the bad, the ugly. And so I am seeing that. And
I think, that's interesting because it does address, as Adam had said, so one of the problems, right? I mean, in some ways, having a nurse or nurse practitioner even, or maybe even a doctor in the dispensary overcomes some of that knowledge barrier, or hopefully it does. But it doesn't really get past the conflict of interest, right? Because now they're in the dispensary as an employee of the dispensary. And unfortunately, I've seen occasions where the nurse giving advice gives the advice that suits the dispensary and not so much the patient. And hopefully that doesn't happen too much because they're great professionals. But, it's tough when somebody's writing you a paycheck, right?
yeah, Suraj, I know you had your hand up earlier.
Yeah, no, I just wanted to piggyback off of Adam and Jordan's comments. I think, with our discussion is really, I think, part of it where we're focusing on safety, ensuring maximal safety for our patients. None of us would want our grandmothers or grandfathers going into a dispensary and getting something that they shouldn't have received, and either, aside from maybe the positive euphoric effects that I'm sure many people would want, but you wouldn't want them to green out or be severely intoxicated or developing, acute paranoia, psychosis, etc. I think, when I look at even physicians here in Canada, many who there's certainly a good number that have gone through the extensive training, self-learning, being competent on knowing how to prescribe and authorize medical cannabis for patients. But then I've come across many who haven't, and just feel because it's legal that, based on the fact that their patients are asking them for it, sometimes feel inclined to, authorize them something, but not knowing, again, the risks versus benefits, and sometimes not being fully aware of any of those risks, whether recent MI or recent stroke, or the fact they're on, blood thinners or antiplatelets, et cetera. And I've seen, if I have concerns with some medical providers who've gone through school for decades, right, and they themselves haven't become fully competent of the potential risk, then I can't expect the same for a bud tender who may have not gone through the extensive amount of training.
I can't tell you how often I hear from a colleague when they wrote a certification and then basically, again, in that sort of California model said, go to the dispensary, they'll tell you what to get. And I'm like, no, don't do that, right? I mean, because, frankly, I think that's malpractice, right? I mean, we are in the position where we need to guide our patients, be specific, make sure that we have met the standard of informed consent, which includes informing, not just getting consent. And to say, dealer's choice, that just doesn't make sense to me. And, just to give an example, sort of back to something that Adam had said, many years ago, for reasons that were totally random, I had two older gentlemen come to me within the space of a month, and they came to me for standard ordinary back pain, right? The problem was both of these guys had liver transplants. I don't know why. I mean, what's the likelihood of having two guys with back pain and liver transplants in the same month? But there you go. Anyhow, I immediately thought, when they go into the dispensary, the first thing that Budtender is going to say is CBD, right? And CBD interacts with their anti-rejection medications, tacrolimus, everolimus, and potentially lethally so. So, I felt like, all right, I caught this one, right? But how many other ones am I not seeing ahead of time? The bud tender shouldn't, for HIPAA, for privacy reasons, be in the position of asking about comorbid history and medications and allergies. That's our job. And we need to be doing that, taking it seriously. And as you have said multiple times, really worrying about the safety of the drug-drug interactions.
You were recently in a dispensary and you overheard a bud talking to a patient, and I know you probably wanted to say something, but you had to put your step back.
Yeah, I was wearing my civilian hat at the time, so I didn't feel like I could rush over. There was a maybe 70-something-year-old woman, and she was talking to this very young bud tender, and she was getting some gummies uh, and I don't actually know what she was getting them for, but he was saying something like, well, you take one, it can take a while to kick in, so wait a couple hours before you take some more. And I'm just thinking, no, don't do that. It can take, a very random period. Most of the time it kicks in an hour, but I wouldn't want to hang my hat on that. And it just, again, it felt like, here was an older woman who had probably every reason to be using this medicine, but needed to be guided to the right and safe outcome. And unfortunately, for whatever reason, she was getting sort of spurious, vague help from this dude. And that was unfortunate.
Dude, do you see the United States changing to the basically the distribution market that's down in Latin America with Sandra being the prescription model? I mean, I know Jazz, GW Pharmaceuticals, Pfizer's about to enter or has entered. And so is it going to be taken away? I know we hear this buzz too. Dr. Carrillo, back down to you in Latin America. It's a prescription. Up here in the United States, it's basically called a recommendation, unless it is Epidiolex. But down there, you're talking prescribing. So you're writing it actually on a prescription pad, sending it to the pharmacy like you would do it, or are they taking it to the pharmacy?
Yes. Yeah, definitely the process is prescription, and only doctors, non-nurses or non-nurse practitioners, are just basically doctors, the one they are allowed to do the prescription, and the prescription goes to a pharmacy, and the prescription goes also to the laboratory that produces the
Gotcha.
in the case of Colombia, we have compound pharmaceuticals like magistral preparation. So it has to go to the lab, because the idea of these prescriptions, particularly in Colombia, is for one single patient, one pathology, one preparation. So like it's supposed to be customized because it's compound pharmaceuticals, and the process is a little bit longer, but still it has to be, the patient has to get it in a pharmacy, that it has to have a license from the narcotics department, and it has to be dispensated by a pharmacist with the proper license, and the doctor has to issue this prescription and it has if it has THC, needs to be like a controlled substance. So I like the system because it's as Suraj was saying, and Jordan, and also Adam, is safety. This is not about egos, that I am a doctor or who studied here, there. It's just about safety of the patient, because safety is one big issue, and we see all these media talking about accidental ingestion, children even taking the gummies that the parents bought, and usually we have to be responsible with this, and this is like a could be like a public health issue if it's not addressed in a proper manner. So I think Latin American models are pretty much like this, prescription, and goes to the pharmacy, the patient buys in the pharmacy, and the model of having like a Budtender is not that common in Latin America. There is some countries, but usually even in Uruguay. I recently was invited by the presidency of Uruguay, because they were celebrating the 10 years after being the first country to legalize recreational and medical. And I found that in Uruguay, the recreational is being sold in pharmacies. It's not by a bartender. They sell it in pharmacies, but they also have these clubs. But they have it in a pharmacy, in the same way that the patient was going to buy a heart medication or a painkiller. It was lining up to buy the recreational or adult use cannabis. So it was interesting to see how Uruguay has that model, but it was interesting seeing the pharmacist doing the dispensation instead of being a budtender, the one who's doing it. But basically in Latin America, is through the pharmacy with a prescription only, and in almost every country in Latin America has to be with a doctor's prescription. At least Uruguay is the only country in Latin America that has adult use allowed. The rest of Latin America is just medical.
So within Latin America, is it, when you're talking about the prescription in the pharmacy there, are they selling flour, or is it just
Yes.
and
And
also,
in some countries in Latin America, there is flour. In Colombia, we still don't have flour. We just have oral presentations. But there is other countries where they allow the flour as a prescription, with prescription for treatment, medical treatments.
I circle
Yeah.
back to something you started to ask a moment ago, and then Suraj, we won't forget you. You started to ask the question of, you know, what's going to happen to the medical program here in the United States, and can we adopt something that is more prescription oriented, like in Latin America? And, you know, when I started ACS, that was very much my hope, was that we would, you know, mature by allowing recreational use. Then we could circle back and make medical sort of more medical, and go to a prescription model and that sort of thing. And what I've seen evolve here, particularly in Massachusetts, which, you know, is a good example of having both systems simultaneously, is that there's so much emphasis on that recreational market that it's really become the cannabis industry is the recreational stuff. And there's this little program over here that's the medical stuff. And I think that that's a huge problem, because number one, people who are using cannabis aren't availing themselves of medical guidance, but also there are a much larger number of people who aren't using cannabis, but who would benefit from it, but they don't see it as a real option, or their doctors don't see it as a real option. And so they're not getting brought into a system. And I think that if the cannabis industry goes in the direction that it seems to be going, what we'll see is just a recreational industry, and the medicine will just go away. And that has sort of led me to what I feel is sort of an unfortunate conclusion, which is that what we are going to end up with sooner or later, and unfortunately it looks like sooner, is recreational markets. And then we're going to have to pray like hell that the pharmaceutical industry figures themselves out in a timely enough manner that there will be pharmaceuticals that we can then prescribe. And there's so much research that goes into that, that even if they started on it today, I think we're 10 to 15 years before they're going to get through the FDA process. And what is going to happen to all of our patients in the interim? That's what keeps me up at night.
That's the challenges are real, and the challenges are really stem from the fact that I can't think of another compound out there on the market that we can prescribe, and yet at the same time somebody can just go on the shelf and buy it. I mean, sure, if we want to prescribe extra strength ibuprofen, we, you know, anything above 800 milligrams is prescription strength, but doesn't prevent anyone from going down and taking 4 of the 200 milligram ones. So how is the industry going to sort through that? And Jordan, like you, I don't know how it's going to shape. How do you separate them?
More is not always better. Can you share how important that statement is? More is not better.
Yeah, no, absolutely. Cannabis definitely, I think, has a relatively narrow window of effectiveness when it comes to dosing, when you're focusing on a particular disease or ailment. The sweet spot for medicinal patients, on average, you're looking at least 10 to 20 milligrams, I would say, on average, per day, which again is not a high dose by any stretch of the imagination for somebody who's using it recreationally and uses it consistently recreationally. Those are lower doses, but so again, there's a distinct difference between using cannabis as a medicine and using it as a recreational enjoyment, if you will.
Yeah. Suraj, you want to
Yeah, I just wanted to say, just kind of put this out there. You would never go to a bud tender to have your blood thinning medications adjusted. You would never go to them to have your seizure medications adjusted. You would never go to them for having your cancer medications adjusted. And likewise, we have to look at medical cannabis as being a medicine and going to someone who has the expertise, knowing everything about you to modify and make those changes. Now, if you want to go to a bud tender or dispensary to get cannabis for recreational purposes, to enjoy, relax, or get high, then sure, that's maybe a reasonable okay. But when it comes to going there for medical purposes, I would have to disagree and say no.
Yeah, well said. I mean, if you're going into the liquor store and asking, what goes well with the filet, I'm having some folks over for dinner on Saturday night, that's just different from, going in and asking them what chemotherapy I should take for my glioblastoma, right? I mean, and it's weird to me that somehow in our society, we've gotten this kind of jumbled up so that, even older folk who, have been around the block a little bit, seem to sort of DIY their healthcare in this narrow area where they clearly wouldn't in other areas. And I think we have to work with all of our colleagues, our medical colleagues, public education, working with the dispensaries and the budtenders, so that we can kind of shift this conversation back so that they're getting safe and effective medical care, as we've been talking about.
Great, thank you. Jordan, can you share, being the leader and founder of this organization, can you share how people can find us?
Yes, absolutely. If people are interested in what we're doing, which is a combination of education for clinicians and lawmakers, as well as policy advocacy, you should check us out online at www.cannaspecialist.org. Again, www.cannaspecialist.org. And we have lots of free information online, plus some courses that people can take and a bunch of resources that allow for sort of a deeper education for people who choose to become members.
Wonderful. So thank you very much. And thank you all, Dr. Sandra Carrillo in Latin America, Dr. Suraj Tandon up in Canada. And I think you're in Florida now, Dr. Abodeely?
Yes, that's correct.
And Dr. Jordan Tishler, Massachusetts. Yes?
You got it.
I'm your host, John Malank, out here in California for the Association of Cannabinoid Specialists. In casual conversation, we'll see you on our next episode. Thank you all.